Okay, everybody. It's about a minute past the hour, so I think we will get started. Hi, good afternoon, good evening. My name is Sarah DeFeo. I am the Vice President of Scientific Affairs and Programs here at Ovarian Cancer Research Alliance. And I want to thank you all for joining us today as we wrap up our webinar series for 2019 with today's presentation on managing recurrence. So just a little bit of background about our organization. OCRA is the largest global organization dedicated to fighting ovarian cancer. We advance research to prevent, treat, and defeat ovarian cancer. We support women and their families before, during, and beyond diagnosis. And we work with all levels of government to ensure ovarian cancer is a priority. Before we get started, just a few little housekeeping notes to go through. All listeners will be in listen-only mode throughout the presentation. We should have some time for questions after the presentation, so if you think of a question as you're listening, just type it into the Q&A box that you should see on the right-hand side of your screen. I will see the questions and will select some to ask Dr. Pennington at the end of the presentation. You guys submitted a lot of excellent questions when you registered. I know we won't have time to get through all of them, but we'll see what we can do. So just, you don't have to wait until the presentation is over to submit your questions. Just type them in as we go. And the webinar should last an hour. And this is being recorded, the audio and the slides. So we will post this on the OCRA website probably tomorrow, and we will let you know when it's up. So you'll be able to go back and revisit the information. So about our presenter, Dr. Katie Pennington. Dr. Pennington is an assistant professor in the Division of Gynecologic Oncology at the University of Washington. She's a full-time practicing clinician with expertise in the management of women with gynecologic malignancies. Her research interests include gynecologic cancer survivorship and ovarian cancer genetics. Dr. Pennington completed her residency in OBGYN at the University of Michigan and then completed her fellowship in gynecologic oncology at the University of Washington. Dr. Pennington was one of the speakers at our Ovarian Cancer National Conference that we had in Seattle this past July. And she was a big hit, and I'm very grateful that she was able to join us again today to give this presentation. So thank you for joining us, Dr. Pennington, and I will pass the mic to you. I'll make you the presenter, and you can get started whenever you're ready. I'm going to unmute you.
All right, can you guys hear me?
Yes, I can hear you. Sound good.
Excellent. All right, so I just wanted to start off by thanking you so much for having me, and thank you for this opportunity to speak. I don't have any disclosures. And so in this talk, I'll be focusing on the management of recurrence. We'll be talking about biochemical recurrence and what that is, and we'll also be talking about platinum-sensitive recurrence and platinum-resistant recurrence. And I'll also talk about some management strategies for common symptoms that women with recurrence may experience. And to try to demonstrate my points and add clarity, we're going to follow a hypothetical patient throughout her cancer treatment. And so we'll start with the hypothetical patient. Pretend her name is Meryl Streep. She is a 51-year-old who has a history of stage 3C high-grade serous ovarian cancer. She had surgery followed by 6 cycles of carboplatin and paclitaxel chemotherapy. And at the end of treatment, her CT scan was normal and her CA-125 was also normal at 6, and she was in remission. And she's been getting follow-up exams and CA-125 levels. So she's been feeling well until 3 years later, her CA-125 started to rise. It was noted to be 40, and they repeated it a few weeks later, and it was 50. She had a CT scan, which was normal. It didn't show any evidence of tumor, and a normal physical exam, and she feels well, doesn't have any symptoms. And so what is a biochemical recurrence? This is a term that we use to describe when we see an increase in CA-125, where that is the only sign that the cancer has come back. And so that is a common question that women will ask is if treatment needs to be started right away. And actually, it doesn't need to be started right away. So there was a clinical trial, a large randomized clinical trial, where women were, and their physicians were randomized to either knowing their CA-125 value or not knowing their CA-125 value. Because a lot of people thought it certainly makes sense that if we can diagnose a recurrence earlier, we can help people have better outcomes. And so we thought that the CA-125 might help us to do that. And so in the early treatment group, as soon as the CA-125 started to rise, chemotherapy was started. In the delayed treatment group, chemotherapy wasn't started until they had other evidence of recurrence. Either they were starting to have symptoms or they saw tumors on the CA-125, on the CT scan. And people were really surprised by this trial that they found that women actually did equally well. They had the same overall survival. And yet, women who received early treatment for the elevated CA-125 started chemotherapy about 5 months sooner. And so what they found from this was that early treatment based on a CA-125 elevated alone results in starting chemo sooner, but it does not improve survival and it did not improve quality of life. In fact, it worsened quality of life because women were starting chemotherapy earlier. And time off of chemotherapy is precious. A lot of people are wondering, well, how could this be? And the way that I try to make sense of it in my mind is that ovarian cancer often responds very well to chemotherapy. It's a very chemosensitive disease often. And so perhaps even if the diagnosis of recurrence isn't diagnosed quite as soon, it's probably more important that we are getting women on chemotherapy when they need for treatment, but that the timing a few months in either direction isn't so critical. And so again, just highlighting women with a biochemical recurrence do not live longer if we start chemotherapy earlier. And so options for management if in this situation are to delay chemotherapy until symptoms develop or signs of recurrence show up on a CT scan. Some providers will offer tamoxifen, which is an oral hormonal therapy that can sometimes be used during this time period, or a clinical trial can also be, you can ask whether or not there are any clinical trials that could be considered. And so we'll go back to our hypothetical patient, Meryl Streep. So she elects for observation of her biochemical recurrence, and she continues to feel well for many months. 6 months later, she'd started developing some symptoms. She developed bloating and nausea, and her CA-125 at this point had risen to 200. And when they get a CT scan, it shows some small nodules in the pelvis and abdomen. And so what does recurrence mean? Why has the cancer, quote, come back? And so what it really means is that the cancer had been there all along, but that the CT scans, which had originally been normal after finishing treatment and the CA-125, just couldn't detect those tiny invisible deposits of ovarian cancer that had unfortunately remained after initial treatment. And so what can be done? I really want to convey that the outlook has really improved and that there are lots of treatment options for women with recurrent ovarian cancer. We have many effective chemotherapies. There are newer targeted biological agents. Immunotherapy sometimes can be used, as well as clinical trials that are advancing the care of women as well. And the goals of treatment when recurrence is diagnosed is to keep the disease under control for as long as possible and to keep you feeling well for as long as possible. And so what are some things that I would encourage you to ask your oncologist if you get diagnosed with recurrence? One of them is knowing about if you've had genetic testing or not. And I have a slide a little bit later where I will be explaining this more. But I think that's important for everyone to know, and it has become an increasingly important part of ovarian cancer care that guides treatment options. You should be asking about what your treatment options are and what your oncologist recommends. asking about if you would qualify for a clinical trial or if there's anything that you should be considering. And then I do think it's also helpful to ask if there's anything unusual about your cancer in particular that should make us consider different treatment options. So for instance, histology, that is what the cells look like under the microscope. High-grade serous ovarian cancer is the most common histology, but there are other types of cancers, for instance, a granulosa cell ovarian cancer, or a low-grade serous ovarian cancer. Those actually behave very differently from high-grade serous ovarian cancer, which is the most common kind, and it makes us sometimes consider different options. I always encourage people to consider a second opinion. None of us as oncologists should ever make our patients feel bad about asking for a second opinion, and we often welcome that. So if that's something that you think would be helpful for you, don't hesitate to ask for that. And then I would like you to encourage you to also ask about palliative care, which I'm going to explain. So what is palliative care? Palliative care is a specialized team of doctors, nurses, social workers, and other specialists, and their job is that they focus on the relief from symptoms and stress from cancer. Their goal is to improve quality of life for you and your family, and can provide an extra layer of support. And so this team can be helpful at any stage, and it's meant to be an addition to your cancer team and not a replacement for your cancer doctor. So I really encourage my patients, if they are interested, to see palliative care as well as seeing me, to see that we can maximize quality of life and be addressing goals and issues that are most important to them. Let's talk a little bit about genetic testing. And this can be a little bit confusing to some people, but genetic testing that is commonly referred to as something that can cause hereditary or inherited ovarian cancer, meaning genes that you can pass down, from mom or dad down to daughter, that can then increase her risk of developing ovarian cancer, for instance. So we know that there are mutations in certain genes, such as BRCA1 and BRCA2, that are really important to identify. There are other genes that can also act similarly to BRCA1 and 2 and increase ovarian cancer risk, such as BRIP1, RAD51C, RAD51D, and others. So what is a gene? A gene is a portion of your DNA that makes a protein. So the BRCA1 gene makes a BRCA1 protein. What is a mutation? That's when you have a change in the sequence of your DNA, an abnormality that makes the protein not work. And so we know that having a germline or inherited mutation in BRCA1 or BRCA2 can increase your risk of developing ovarian cancer or breast cancer. And so there's two types of genetic testing. And again, I recognize this can get confusing, but it's becoming important now as we are learning more and more about optimal ways to treat ovarian cancer. So germline testing, or testing for mutations, is testing for inherited mutations. Again, those are the ones that are passed down from your mom or your dad. And if you inherit that mutation, that means it's in all of the cells in your body. Every single cell has that mutation. And you can identify that either with a blood test or a cheek swab. Somatic testing, or what we call tumor testing, tests for mutations that are not inherited, that they actually spontaneously arose in the tumor. And so you would detect those by doing a biopsy of the tumor and testing it. And you would see that mutation only in the tumor and not in all of the cells of your body. So it would be an acquired mutation. And both of these can be relevant for the care of women with ovarian cancer. Although I often see patients who may have had germline testing, but they haven't necessarily always had the tumor testing, which can be sometimes relevant. And so why should you have genetic testing? This may influence treatment options for your ovarian cancer. So some of you may be aware now that women with BRCA1 and 2 mutations that either in the tumor that have arisen spontaneously or that they've inherited, so germline or somatic, that you would qualify for maintenance therapy with a PARP inhibitor after primary therapy. So first-time diagnosis of ovarian cancer, you do your surgery and 6 cycles of chemotherapy typically, and then can go on a PARP inhibitor, which has really improved outcomes for these women. So it's important to identify those mutations. Germline inherited mutations also can influence screening recommendations for other cancers, for instance, breast cancer risk, and it can be helpful to family members. And so I'm going to give an example about that with Meryl Streep. So she has a germline or BRCA1 inherited mutation, which means that PARP inhibitor therapy may be particularly helpful for her treatment, and we'll get into that in more details later. But it also affects her family members. So let's pretend she has a daughter, Grace, who also has the BRCA1 mutation. She inherited it from her mom. She then now knows that she has an increased risk of breast and ovarian cancer, and we have many strategies for risk reduction or ways to actually prevent these cancers from happening. So that's very useful to know so that she can decide if that's an option of interest to her. In contrast, her sister Mary has been very worried about developing ovarian cancer because actually not only has her mom, Meryl Streep, had a diagnosis of ovarian cancer, but many people in her family did. And so this whole time she's been worrying about this, but she got her testing and discovered that she does not have the BRCA1 mutation gene, that she did not inherit it from her mom. There was only a 50% chance she inherited it. And so she actually does not have an increased risk of breast or ovarian cancer screening and does not need to think about more intensive screening or risk reduction strategies. So that's some ways that can be helpful. I'll switch gears now and just talk about general treatment options for recurrence of ovarian cancer. And so generally, anytime I'm thinking about treatment, I think about three basic categories. Surgery is one option, and that's often a very important part in a new diagnosis of ovarian cancer. Chemotherapy or other systemic therapy is treatment that can go to all cells in the body, and that can be advantageous because even there can be areas where cancer cells may be that we can't necessarily see on a CT scan, but that the chemotherapy can still treat those areas. And then radiation therapy is not often used because ovarian cancer frequently comes back at several areas within the abdomen, and radiotherapy is really best suited to disease that is confined to a limited area because you can get side effects from the radiation that can affect the normal tissues surrounding that area. However, it can sometimes be used to control symptoms in certain circumstances. And so first what I'll talk about is, well, what about another surgery followed by chemotherapy? So, that's what many women with their initial diagnosis of ovarian cancer had, was both surgery and chemotherapy. Should we do that again? And so surgery may be considered, but we actually have very recent clinical trials, one that just recently got published, where at the time of recurrence, women were randomized to getting surgery followed by chemotherapy or just getting chemotherapy alone. And we actually found that women did better with just getting chemotherapy compared to surgery and then chemo. Surgery did not help people to live longer, and women were having to undergo a surgery. So what we've learned from this is that surgery is likely not beneficial for most women. It can be considered in certain select situations. I alluded to women who have a granulosa cell ovarian cancer or low-grade ovarian cancers, which are less common types. Sometimes we rely on surgery more in those instances. It's a little bit of a different paradigm of treating. But for most women with high-grade serous ovarian cancer and kind of the most common types of ovarian cancer, we know that surgery is unlikely to be beneficial in most circumstances. And so next I'll talk about chemotherapy, some general considerations, and how we decide about selecting chemotherapy. An important issue is timing of the recurrence. So how long since the patient finished their last chemotherapy treatment with platinum, such as carboplatin, if the recurrence hasn't happened for 6 months or longer, then we think of that recurrence as a platinum-sensitive recurrence. If the recurrence happens in less than 6 months, we consider it a platinum-resistant recurrence, and I'll explain more about that. And so Platinum-sensitive recurrence, or that's a recurrence that has come back more than 6 months after finishing prior treatment, means that there is a greater chance that the cancer will respond to platinum-based chemotherapy again. And so in this situation, we want to retreat with carboplatin, usually plus another drug, or what we call a carboplatin doublet. Some common choices are carboplatin and liposomal doxorubicin, or Doxil is the brand name for that. Carboplatin and paclitaxel again, or Taxol, which is often used with initial diagnosis, as well as carboplatin and gemcitabine, or Gemzar. There are other choices, but these are some of the most common. And so how do you pick a regimen? Each regimen can be effective, and they each have different side effects and dosing schedules, and so that often will guide us when we're selecting. Going to the middle regimen here, the carboplatin and paclitaxel, that is usually given every 3 weeks, or it sometimes can be weekly. And some of the notable side effects for it is that it usually causes hair loss, especially when it's given every 3 weeks. And neuropathy, or numbness and tingling in the fingers and toes, are some of the common side effects. Going to the top here, carboplatin and Doxil, that's a very different side effect profile. That's given every 4 weeks instead of every 3 weeks, which can be nice to have a little bit of a break in between infusion schedules. And it doesn't cause hair loss and doesn't tend to cause neuropathy. It can cause mouth sores and something called hand-foot syndrome, where you can get cracking of the skin on the hands and the feet, or redness or sores. And those are things that we have to manage or try to prevent. And then the last regimen that I highlighted is carboplatin and gemcitabine, or Gemzar. That's given day 1 and day 8 every 3 weeks. So you get it on Monday, the following Monday, then you'd have a Monday off, and then you'd start back again with the next cycle. And that tends to be harder on the blood counts. It can cause anemia or low red blood cells. It can cause low white blood cells and low platelets. And it can also cause swelling or rash. And again, each of these regimens are known to be effective for ovarian cancer. And so how many cycles do we recommend? So the answer to that depends. It's usually at least 6, but possibly more. And the goal really is to treat to maximal response. We're trying, if possible, to get another remission, meaning that the CT scan shows that all of the tumor nodules went away and that the CA-125 normalized again. And so after 6 cycles, if a remission has been achieved, we don't usually give additional chemotherapy. But if we see that the tumors have shrunk some, but they haven't completely gone away, then we keep giving the chemotherapy to try to shrink the cancer as much as possible. And so the number of cycles really depends on each individual situation. And so let's go back to Meryl Streep. So if you remember, she's now 3.5 years out roughly from finishing her initial chemotherapy. And so her cancer would be considered a platinum-sensitive recurrence. And so she and her provider opted to treat with carboplatin and liposomal doxorubicin, or Doxil. She got 6 cycles, and she got a repeat CT scan and CA-125, which were both normal. So she got in remission again. So what next? So maintenance therapy is something that can often be considered. Maintenance therapy is a treatment that is given after chemotherapy, and it's given to continue or maintain good results of a prior treatment. And the goal in giving it is to delay the time before a new recurrence or progression of existing disease occurs. So the hope is that if we put someone on maintenance therapy, that even if their cancer does come back again, hopefully it can take much, much, much longer to come back, and that they can have time off of chemotherapy. And so what are the things that I want patients to know about maintenance therapy, and that I want you to be asking your oncologist? It's really important to ask how you can expect to feel on the maintenance therapy. And I'll go through a couple of the most common maintenance therapies there are, but there still can be side effects. So you need to know what is the potential benefit. People, for instance, if there were a maintenance therapy that had a lot of side effects and made people feel terrible on it, and it only delayed the cancer coming back by 1 month, many people might say, I don't find that worth it. That's not enough benefit for me feeling very poorly on this drug. On the other hand, if there aren't a lot of side effects, or the benefit is a lot greater, for instance, if there's the potential to delay recurrence by years, then people might make different choices. So when you're speaking with your oncologist, those are things that you can ask about. It's important to remember that when you're getting maintenance therapy, that sometimes can mean still needing to come in for infusions if it's an IV drug, blood work or monitoring to monitor your counts and your kidney function and things, and other things that can remind you of your cancer diagnosis. And then I think it's important to think about what are your priorities. Is your priority to be able to work? Is it being able to travel? If someone needs to go into the infusion center every 3 weeks in order to get maintenance therapy, does that inhibit your goal of being able to travel? I do think while we talk about travel, it's important to say that many of us as oncologists work really hard to work around your schedule so that you can still be doing things like traveling and other things that are important to you. Time off of chemo, if being off of chemo for as long as possible is really important to you, then maintenance therapy may be something that you want to consider if we think that it could be a successful strategy. Or is it important to be feeling symptom-free and not having side effects? So those are just some of the considerations, and it's really a very nuanced discussion, and it's a team, I work, in partnership with my patients to help them decide what's right for them. And so there are a couple commonly considered options for maintenance therapy. One of them is called Bevacizumab or Avastin. Bevacizumab is something that actually, if we elect to give it, usually is given with the chemotherapy, but then when the chemotherapy is done, is continued afterwards for maintenance. And again, for as long as it's working and someone is tolerating it well, we continue it. The other option for maintenance therapy that is commonly considered is PARP inhibitors, and I'm going to explain more about each of these. I also don't have it on this slide, but for some of the less common types of ovarian cancer, for instance, the granulosa cell tumor or low-grade serous ovarian cancer, sometimes hormonal therapy can be used as a maintenance therapy as well. And so first, let's talk about Bevacizumab or Avastin. So that's the one that's given during chemotherapy and then continued afterwards. This is an IV drug that's given every 3 weeks. It does not affect blood counts, and it's usually minimal fatigue. And so often patients can actually feel pretty well on this drug. Some common side effects are high blood pressure. Up to 25% of patients might need to go on a blood pressure medicine or even sometimes more than one medicine to help keep the blood pressure controlled. And it sometimes can affect kidney function, and so we monitor for this. There are also some uncommon or rare side effects. And again, they're rare, but they can be very serious if they happen, and so that needs to be taken into consideration as well. A patient could develop a bowel perforation or a hole in the bowel. There are certain situations where we think someone might be at higher risk of developing this, where we might not offer Avastin, but even people who don't have risk factors, there's still a small risk this could happen. And there's a small risk of stroke. There's a risk of getting a blood clot in your leg or in your lungs. And so PARP inhibitors are the other common maintenance therapy. And so PARP inhibitors are oral drugs. Some of the drugs are called olaparib or Lynparza, niraparib or Zejula, and rucaparib or Rubraca. And it's an oral drug that's either taken once or twice a day, depending on the specific drug. And something that's important about this is that it's particularly effective for cancers with BRCA1 or BRCA2 mutations. Those mutations can be inherited, like Meryl Streep is, where it's in all of the cells in the body, or if it's in the tumor only and is sporadic or somatic. And so some common side effects of PARP inhibitors can be fatigue, nausea and vomiting, and decreased blood counts. And so those are things that have to be monitored. The fatigue and the nausea are often things that can improve after being on the PARP inhibitor for several weeks or a month or so. And it's not that people have learned to tolerate the symptoms, but actually that the body gets used to the drug and the symptoms can lessen. So that's important to know. And then we also have many strategies for controlling those symptoms if they're happening. And so Meryl Streep, again, because she has an inherited BRCA1 mutation, started on olaparib maintenance after she got into remission from her carbodoxil. And so I'm going to talk through, pretend she didn't have that inherited mutation. So she didn't have it in all cells in her body. Then in that case, for her to know if there's any mutations in her tumor is really important. Because scenario one, pretend that there are no mutations in her tumor, then her options are not to do any maintenance therapy. She could do maintenance therapy with bevacizumab, or she could do maintenance with the PARP inhibitor. And again, they each have their own profiles and risks and benefits. Scenario two, let's say she had that mutation, a BRCA1 or BRCA2 mutation in her tumor. The options are the same, but then a PARP inhibitor should strongly be considered for maintenance therapy because we know that these work so much better. They still work even in women and in tumors without the mutations, but they work even better in tumors that have these mutations. And so if I have a patient who's had germline testing that didn't show anything, nothing inherited, then I do want her tumor to be tested because if I identified a BRCA1 or 2 mutation, that gives us important information when we're weighing the pros and cons of different maintenance therapies. And so Meryl Streep started on olaparib maintenance, and she felt well on it, and her CA125 remained normal throughout. And so 2 years later, she unfortunately started to have a rising CA125 and new urinary symptoms and pelvic discomfort, and the CT scan confirmed recurrence again. And so again, because it's been 2 years since her last platinum chemotherapy, this would still again be considered a platinum-sensitive recurrence. And so this time, she opted with her providers to go on to carboplatin, gemcitabine, and bevacizumab, and then continue bevacizumab maintenance. And she had a complete response to chemotherapy and was in remission again. So unfortunately, 5 months later, after finishing the carboplatin, gemcitabine portion of her chemotherapy, she developed a new swelling in her abdomen. And the CT scan confirmed recurrence. It showed nodules in the abdomen, but it also showed something called ascites, or fluid in the abdomen. And so going back to general considerations for the timing of recurrence, in this case now, because it's only been 5 months, we would categorize her tumor as platinum resistant. A platinum-resistant recurrence means that there is a lower chance that cancer will respond to platinum-based chemotherapy again. And so usually in that instance, we don't do a carboplatin doublet, but we do still have numerous options for chemotherapy. Some of the most common choices are weekly paclitaxel or Taxol, liposomal doxorubicin or Doxil, topotecan or Hypothetic. Again, gemcitabine is an option. There are many other options. I haven't listed them all, but those are some common choices. And like with a platinum-sensitive recurrence and maintenance therapy, bevacizumab has also been approved as a maintenance therapy in the platinum-resistant setting. And so not only are the options Taxol, Doxil, Hypothetic, but you could also do Taxol with Avastin, Doxil with Avastin, or topotecan with Avastin, followed by bevacizumab maintenance. And I'll actually just add something to that, which is that bevacizumab has been studied in the platinum-resistant setting, and we know that it can help improve response rates to chemotherapy, but it seems particularly effective for patients that have ascites or fluid in their abdomen or effusions, fluid in the lungs, and it has been shown to improve quality of life. And so that's a consideration when talking about options for treatment. And so Meryl Streep has a platinum-resistant recurrence. She started on weekly paclitaxel with bevacizumab. And what we found this time is that her tumor initially decreased with treatment, but then after a period of time, unfortunately, it started growing again. And so at this point, we'll talk about other options for treatment. So there are still many more traditional chemotherapy options. In targeted therapy, bevacizumab, if a patient hasn't had it previously, that can be given just by itself or, again, in combination with chemotherapy. PARP inhibitors, if they hadn't been given before, are approved for BRCA1 and 2 mutations. And then also, sometimes there are other novel agents, and this, again, is where tumor testing can come in. Occasionally, testing the tumor can find a unique mutation that might predict another novel therapy could be useful. There's a lot of excitement and interest in immunotherapy, and this is not widely used for all ovarian cancers, but for tumors that specifically have an abnormality called microsatellite instability or microsatellite instability high or mismatch repair deficiency, those tumors are predicted to respond to immunotherapy. And so a drug called pembrolizumab or Keytruda is approved for that indication. Hormone therapy is another option that can be considered. And so Meryl Streep, she had not had tumor testing before because since we had known that she had this BRCA1 mutation in all cells in her body, and we had good options, it wasn't going to change our management. But now we're looking for other options, and so we opted to test her tumor as well to say, well, what if there are other mutations or findings besides the BRCA1 mutation that we know the tumor already has that might guide our therapy? And for her tumor biopsy, it showed not only the BRCA1 mutation, but it also showed that there was microsatellite instability, that MSI high, that was present. And because of that, that predicts that immunotherapy may be effective. And so Meryl was started on pembrolizumab for her next treatment. The other thing I'd like to talk about is clinical trials. So these are research studies to test a new treatment. The drug is typically evaluated in 3 clinical trial phases before it can become a standard treatment option. And clinical trial basics, the OCRA has a really nice section describing how clinical trials work and considerations if you're thinking about clinical trials. And so how can you find a clinical trial? You can ask your oncologist if they know of any trials that you would be eligible for. You can also search on clinicaltrials.gov, which requires all clinical trials be registered, or on Emerging Med, and that application actually may be a little bit more user-friendly and easier to search with. So what are the potential benefits of participating in a clinical trial? There's the possibility of getting a new treatment before it's widely available, and possibly being one of the first women to benefit if the drug works. And also helping advance medical knowledge for the benefit of women now and in the future. And we actually know that even women who participate in phase 3 trials, which are often randomized, say to standard of care versus the experimental study drug, many women are hoping that they might get the experimental study drug, but we know that actually there is benefit from participating into a clinical trial even when patients don't receive the study drug. Often that's because the trial design means additional care and monitoring. I'd like to briefly talk about complementary therapy as well. The majority of my patients are using some form of complementary therapy, and I really do think it complements the care that we're providing. Women are often seeking therapies to help manage symptoms and side effects that they feel conventional medicine has not always managed well, or to decrease anxiety, depression, or stress. For some of these things, mind-body therapies such as acupuncture or massage therapy or meditation may be helpful, and there are many others. And then herbs and dietary supplements are common as well. If you opt to go on herbs or dietary supplements, I really encourage you to tell your oncologist because even though some of these are herbs or what people perceive as natural, they can interact with other drugs that you may be taking. And the Memorial Sloan Kettering Cancer Center's About Herbs database is pretty nice. You can check it out if you're interested. And that's a useful resource for providers as well. So next I'd like to shift gears and talk about some common symptoms and side effects from chemotherapy and from having recurrence. And I really want to estimate, please talk to your care team about the symptoms that you're having. You deserve to feel your best, and we can't help you with those symptoms if we don't know that you're having them. I always make sure my patients know it's not complaining, it's reporting. You're giving us important information that we know to help give you the best care possible. This list is not exhaustive, but some common symptoms or side effects that are experienced that I'll touch on are things like neuropathy, nausea, fatigue, pain, distress, and changes in sexual function. And so I'd like to start with neuropathy. Neuropathy is numbness or tingling or pain or a temperature sensitivity that's most commonly in the hands or the feet. It can be caused by many different chemotherapies, but one of the most common chemotherapies that can cause it is the paclitaxel or Taxol. Prevention for neuropathy, I think, is one of the key issues. One thing that can help is actually icing the hands and the feet during the taxane infusion. So we actually have our patients get, mittens and booties that they keep in the freezer. They'll bring a couple pairs and they can wear it during the Taxol infusion. And as one is getting warm, they swap it out for the other one that's in the freezer. And we have found that this is making a difference for our patients. And there are some studies also suggesting a benefit that it decreases neuropathy rates. Studies are pretty mixed about if supplements help or not, but some patients have found these to be helpful. And then there's some studies suggesting exercise may be beneficial as well. It's really important that you communicate with your provider about your symptoms. Neuropathy can go away when the chemotherapy is complete, but it doesn't always. And so the last thing we want to do is cause neuropathy that's so bad that you're tripping or having significant pain that's really reducing your quality of life. I would never want to risk the neuropathy being at a level that doesn't go away. So if your neuropathy, it can be normal to have some neuropathy during the chemotherapy, but if it is getting a lot worse or really bothersome to you, please let your provider know. We can reduce the dose of chemotherapy or change the dosing schedule or even change to a completely different chemotherapy drug, all without compromising the efficacy of your cancer treatment and keeping your cancer treatment still successful. So please keep us in the loop. In terms of if neuropathy develops and ways to manage it, duloxetine is an antidepressant actually that we learned can help with neuropathy symptoms, so that can be considered as a medication. Gabapentin, some patients have found helpful. That's a medication originally used for seizures, but has been found to have other benefits, such as sometimes for neuropathy. There's also a topical treatment with 3 drugs called amitriptyline, ketamine, and baclofen. That one is less commonly known about, but the data looks promising. It does have to be made at a special compounding pharmacy. Some patients feel like CBD oil can help their neuropathy or discomfort. And then physical therapy can be helpful as well, especially if someone is having balance trouble or weakness from the neuropathy. They can strengthen their muscles and improve the body strength to hopefully decrease the risk of falls. Acupuncture can also sometimes be helpful. Nausea is another common side effect. And I'm trying to put on here some things that will help give you some tools to report it to your provider so that they can have the most information about when it's happening to help figure out what's causing it, because different causes get managed differently. And so you can inform your provider if you're having nausea, when are you having it? Is it related to the chemotherapy? Is it during the chemotherapy? Or is it after? Is it delayed? Is it on day 4 after your chemotherapy? We do different things with that. Is it all the time? Or is it only brought on by eating, for instance? How severe is it? What have you done so far that helps, or what have you tried that doesn't help? All of those things can give us clues for management. If it's related to chemotherapy, other medications may be added, or sometimes we can add extra hydration or other ways to manage it. If it's related to the bowel not working well, then other interventions can be offered. Fatigue is a big symptom that really can limit quality of life for many people. And it has been very well studied that exercise can very significantly reduce cancer-related fatigue. I think that's a tough one because when you're feeling tired, it's hard to think about exercising, but the studies are really quite robust that this can make a difference. And so I encourage patients as one strategy to try to do some light exercise, brisk walking, or if you can't do brisk walking, slow walking, and say, I'm going to just do it for 5 minutes. And if after 5 minutes I'm too tired, I can stop. But often if you start, you might find you can even continue it a little bit longer. And doing a little bit every day really can help make a difference over time. We also want to treat sleep disturbances. So if someone's having insomnia, which is very common in our patients, sleep hygiene can be very helpful. So lying down and getting up at consistent times, avoiding caffeine or stimulating activity in the evening right before going to bed, avoiding late afternoon naps, things like that can sometimes help. Stress reduction can be effective, and then sometimes medications for insomnia can also be helpful. Fatigue can also improve with relaxation therapy or mind-body interventions. Managing distress, when you're feeling distressed, that certainly makes fatigue worse. And then something called cognitive behavioral therapy or counseling is something where they can actually help provide specific strategies on how to adapt and manage symptoms. So for example, self-monitoring is this technique where you become aware of when you are most energetic and effective, and you can prioritize and pace your activities to kind of fit with how you're, when you're having symptoms. And then sometimes a psychostimulant has been tried as well, with some people find that helpful and some don't. Pain, we really want you to help us to qualify the pain and quantify the pain. So describe it. Is it burning or sharp or dull or stabbing? How often is it and how severe is it? What do you find brings it on? Is it brought on by eating, or is it brought on by certain physical activities, or is it all the time? Is it at night? Is there anything that makes it feel better? All of those things can help us figure out how best to treat pain. There are a lot of options besides narcotics, Tylenol, ibuprofen, often in combination. There are some antidepressants, such as duloxetine, which I discussed earlier, that can affect the pain pathways in the brain and help decrease pain. Some anti-seizure medicines can be particularly helpful for neuropathic pain. Topical lidocaine or a numbing patch can sometimes be helpful, and some patients have found CBD oil or cannabinoids to be helpful. And then for narcotics, there are short-acting ones and longer-acting ones that can stay in your system for longer. Palliative radiation therapy can be used at certain times. If your tumor is causing particular pain in a certain spot, then sometimes that can be considered. Or if the cancer is involving a bone and causing bony pain. And then also a pain specialist may be able to work alongside your oncologist to manage your pain. Distress, there are a lot of different ways to focus on improving distress, and it really depends on what is causing the distress. Cancer education can be helpful, and what I mean by that is if someone's feeling very worried or very anxious because they don't know what to expect with a treatment that they've never had before, or they're really worried, talking with their provider and getting more information about their cancer can be helpful to know what to expect. A chaplain or spiritual care, social work can be helpful, counseling or groups, support groups. Exercise has been shown to decrease distress, and then many complementary therapies. And then if someone is experiencing depression and anxiety, medications as well as counseling can be important. And, cognitive behavioral therapy is something that can help reduce what we call maladaptive thoughts, or addressing if you're having thoughts that are making things harder for you. Sometimes you can reframe those. So there are a lot of different ways to work on distress, even though it is a complex issue. There are a lot of different support groups. These are just a few. So GYN cancer, if you, GYN CSM, if you use Twitter, and then there are ones you can look for online, and you can search for other ones in your area as well. And then changes in sexual function is, another issue I'd like to discuss because this is very, very common. Some issues can be things like vaginal dryness or pain with intercourse or decreased sexual interest. This is a complex issue. Decreased sexual interest and these symptoms can be due to a lot of things. How someone feels can be affected by undergoing surgery, chemotherapy. If your ovarian cancer diagnosis and treatment caused you to go under menopause, that can be a significant change. Sometimes people feel different about their own bodies or just feel emotionally different. Sometimes it feels changes how you feel about your partner or changes intimacy between the two of you. Or if you're having depression or anxiety from your cancer, that can influence sexual interest. Or sometimes, for instance, if you're having urinary symptoms or bowel symptoms, that can be impacting things. And so I really encourage my patients to please discuss it with their doctor, and I try to ask patients about it as well. It's often something that can be addressed, but a treatment team can be helpful. So not just a gynecologic oncologist or a gynecologist and medical oncologist, but sometimes a pelvic floor physical therapist and or a sex therapist or psychotherapist. But depending on what the issue is, there are a lot of different ways to address it. So I encourage you to bring it up with your provider. So take-home points from the talk that I'd like to convey. There are many effective treatment options for recurrent ovarian cancer and many promising treatments becoming available. Genetic testing is important and may guide treatment. And then I really encourage you to involve your oncology team and the palliative care team to manage symptoms and improve quality of life. Here are some extra resources. There are many great resources out there. The NCCN guidelines for patients on ovarian cancer treatment and also supportive care. Target Ovarian Cancer has an information provided on recurrence. The OCRA has amazing resources, as well as National Ovarian Cancer Coalition and Foundation for Women's Cancer, just to name a few. And at this point, I'll be happy to answer questions.
Great. Thank you so much, Dr. Pennington, for that great presentation. Tons of information in there. And just to say it again, for any of you who may have missed it, this is being recorded, so we'll have it posted on the OCRA website probably tomorrow afternoon. We will email everybody when it is up, so you can go back and listen to the presentation again. Okay, we have just a few minutes for questions. So the first one I'll ask you, Dr. Pennington, is sort of a broad one, but I thought it would be helpful for everyone to hear your reaction. Someone's asked, from your presentation, I hear the assumption that once you have ovarian cancer, you will be faced with having it forever. What is the data for people who are actually cured or eliminated or have eliminated the cancer? Shouldn't we all hope for this?
Thank you. That's a great question, and I appreciate you asking it. If the cancer has come back, especially if it has come back in multiple areas, the vast majority of time, usually we can often strive to get into a remission again, but it usually does keep coming back and require additional treatments. That is not true for everybody. There absolutely are cases where even if it has come back once, that it can be cured. So I share that hope with my patients, and that is a possibility. You are 100% correct. That's not the most common though, and so that's why mostly I focus on making sure we're trying to get in a remission and helping people to live for as long as possible and as high a quality of life as possible. And women can live for many, many, many years, even if the cancer does keep coming back. So yes, I absolutely hope for a cure for every single one of my patients. It's not common, but that can happen.
Thank you. And as sort of a follow-up to that, we have a few questions that came in along the lines of, I'm 7 years in remission, I'm 5 years in remission. I think what people are interested in knowing is is there a point at which they can kind of relax and be less concerned about reoccurrence, or is it something that most patients stay worried about? What do
Mm-hmm.
you think?
Yeah, that's a great question. So the longer that you have been in remission without it coming back, the more and more hopeful I get that you are cured. There is never a time when we can say definitively, because you've gotten this many years out, we know for sure you are cured, because the only way we can know is if the cancer doesn't come back. But occasionally it can come back later, even after many, many years. And so I never tell a patient, for instance, if they've gone 5 years that they are cured, though I am very hopeful that they might be cured. So I have had a patient have a recurrence at 11 years out, and that's not common. So I think, most, women, you can be celebrating, every year that you go that you're not having a recurrence, you can celebrate and start feeling very good. But I do still think we need to be here to support our patients and follow them.
Yep. Someone has asked a question about secondary debulking for recurrent ovarian cancer. I'm wondering if you could talk a little bit about a little bit more about this, about surgery and how it is or isn't used in recurrence, and what the evidence shows for how useful that is.
Yeah, thank you for bringing that up. So I talked about that a little bit in my talk, that when a cancer is initially diagnosed, we use a combination of strategies of surgery and chemotherapy. And for a long time, we thought surgery was a pretty important part, possibly for if the cancer came back in certain circumstances. For instance, if the cancer took a while to come back, or if it was only in a few spots. But they actually just published a large randomized controlled clinical trial through our Gynecologic Oncology cancer group, where this very situation was studied, where women who their cancer came back, they were randomized to either getting surgery followed by chemotherapy or chemotherapy alone. And what we found is that the overall survival was not better with surgery, that actually the survival was better with the chemotherapy alone. And so the reason I think that may be true is, again, ovarian cancer is often a cancer that responds so well to chemotherapy that maybe surgery just isn't even needed in that setting. And so by doing surgery, that's putting you at risk of having complications from the surgery, but also delaying the chemotherapy that we think is the most critical portion. And so that's pretty robust data. There are a couple other clinical trials that are still being done that haven't been reported. There's one called the Desktop 3 trial in Europe that they're still collecting survival information on. And so it will be nice to have that information as well to combine with this GOG trial information. But right now it really looks like chemotherapy is the most important part of recurrence, and that surgery isn't improving outcomes in the recurrent setting. I do think there are caveats to that, like I said, for very specific tumor types like granulosa cell or low-grade ovarian cancer, or even in the regular type of ovarian cancer, there can be certain select situations. But for most women, we don't usually recommend it now.
There were a ton of questions that came in about PARP inhibitors, various things related to PARP. One that many people asked is, if one PARP inhibitor doesn't work, should another one be tried?
That is a great question, and that is one that all of us in the oncology community are asking right now, and we don't know the answer to that question yet. That's actively being studied. And it's really important to figure out, as we are using these more broadly, for instance, now we're using them with initial diagnosis for our BRCA1 and 2 mutation carriers, for instance. Then if they go 5 years without a recurrence, but then the cancer comes back, should we give them a PARP inhibitor again? And I think it will likely depend on what caused. I think there are different situations. So let's say someone was in remission and they were on maintenance therapy, and their cancer didn't come back for a long time. That could be a very different situation. Maybe a PARP inhibitor again may be effective. We don't know yet. That might be very different than someone who had their cancer come back. They went on a PARP inhibitor to try to treat it, and their cancer unfortunately didn't respond to it. Then I might be a little bit less hopeful that trying a different PARP would work. So there's a lot of work to be done on this area, a lot more for us to learn.
Thank you. Okay. We had a bunch of questions that were sort of all variations on this theme. If you're platinum resistant, is there a chance that you might become platinum sensitive in the future during recurrence, or vice versa?
Thank you for asking that. So platinum resistance, when we use those categories, I showed the definitions of less than 6 months or 6 months or greater. Those are actually not, those are predictions of what we would think would happen if we treated with platinum again. And so usually if someone's tumor came back in less than 6 months, it's called a platinum resistant recurrence. And we know from older studies that there's just a lower chance that if we treated with platinum again, that we would get a response. That doesn't mean that actually you might not have a response. And so I do have platinum resistant patients where I will revisit platinum and we can treat with platinum again, and sometimes we can see it respond. And it's probably a little bit more nuanced for this discussion than we can talk about when we decide to do that or not. But there are times when even when someone's tumor is classified as platinum resistant, that they can still sometimes benefit from platinum.
Thank you. We are out of time, but I'm going to ask this question because there were a bunch of questions about tumor testing. Let's see. Does it make sense to, if someone has had tumor testing a few years ago, does it make sense for them to, say, have it retested again now, or to have it retested periodically because new information, is always being found? Also, question about tumor testing is, at what point do you recommend that tumor testing occur?
Those are great questions. So with the first question, if someone has already had their tumor tested, a few years ago, the question is, should we retest? And I hope we'll learn more about this to help guide us better. What we've looked at it so far is that often those mutations are pretty similar. If you get it, a few years ago and then you got it again, they aren't often necessarily very different where it's changing treatment recommendations. So it's something that can be considered, but I don't consider that mandatory. The second question was, when is the ideal time to test the tumor? And I think it really depends. So if I have a patient who has a new diagnosis of ovarian cancer, and she has a BRCA1 mutation that she inherited in her, through the blood test, I wouldn't, if I've met them and they haven't had the tumor testing, I wouldn't necessarily order separate tumor testing because I already know exactly what treatment I'm going to recommend for her. In the example I gave with Meryl Streep, she didn't have tumor testing initially, but then later in her course, she got tumor testing to see, well, what if immunotherapy should be an option? But immunotherapy wasn't going to be something in the initial diagnosis that would have driven treatment. We had other treatments to offer her earlier. There are a lot of different ways to do the tumor. But let's say I have a patient who did not have any inherited mutations. Then I want to test their tumor right then and there, because if their tumor has a BRCA1 or 2 mutation, which is about 5% of women for the tumor mutations, then that would make me want to consider a PARP inhibitor for her, for instance. So it depends on the specific situation. At our institution, we actually, when we first diagnose their cancer, we do both testing at once in one test. That's very special with how our lab medicine can do the testing, but they can test both. And so we get all of that information at once. But if someone only has one of them done, because sometimes insurances will or won't cover the tumor testing, then I've kind of explained some strategies about when I really want to have that done. If it's not going to change my management right now, I generally wait until later when I think it will change my management. Going back to, again, that idea of what if it might be different in a few years, the testing.
Okay, great, very helpful. It is 5 past, so I think we're going to end it there. There were so many great questions. We really could go on forever. Um, so I'm sorry we're not getting all your questions answered here today. I do want to encourage, um, if you, for those of you who have questions but didn't have them answered, I encourage you to go to our online community on inspire.com. You won't get medical advice there from a doctor, but you will find thousands of other ovarian cancer patients and survivors there in the ovarian cancer community. And it's a great place to ask questions, to learn from other women about what they've done, hear from them about their experiences, and just a great place to get support and give support. So that's inspire.com, and just search for the ovarian cancer community. Okay, so thank you so much, Dr. Pennington.
That I'll encourage you to ask your doctor these questions
Yes,
too.
yes, of course.
We want you to ask them and for us to engage and be able to answer them. So
yes, that's right. Yes, thank you. So thank you, Dr. Pennington. Thank you all for calling in and listening today. Please take a minute to fill out the survey that will appear on your screen. When we're done here, your feedback is super helpful to us. I read them all. Your ideas are very helpful as I put together future webinars. And again, this is being recorded, so feel free to listen again. And for more information about OCRA and ovarian cancer, you can always visit our website, www.ocrahope.org. So thank you all. Have a great evening. Happy holidays. And we will be back in 2020 with more webinars. So stay tuned. Thank you, everybody.
all right, thank you all so much.
Thanks.